Hey, hello everyone. Thank you so much for joining us. Good evening or good afternoon, depending on where in the world you're joining us from. Dr. Oyama's main clinical and research interests involve mitral valve disease, novel therapies for heart failure, clinical epidemiology, and cardiac biomarkers. Dr. Oyama has published over 100 scientific manuscripts and abstracts and has given more than 150 national and international lectures. So we hope you have lots of questions for Dr. Oyama during the webinar. So now it is with great pleasure that I welcome Dr. Oyama to speak about congestive heart failure management in the dog.
Thank you and welcome to this presentation titled Management of Chronic Congestive Heart Failure in the Dog. My name is Mark Oyama and I'm a cardiologist from the University of Pennsylvania. These are my disclosures that include research funding, reimbursement of travel and expenses, honoraria, and speaking fees from a number of companies including SIVA, the sponsor of this webinar. What I would like to try and do is answer some of the most relevant questions surrounding heart failure in the dog. The questions and answers hopefully will give you confidence and guidance regarding why it is chronic heart failure develops, which drugs to prescribe and when, how to assess efficacy of drugs and titrate doses, what signs occur indicating that conventional therapy is no longer adequately controlling congestion, and what treatment strategies are available in these instances. A couple of other topics we will discuss is prognosis. Owners and vets want to know how long might the dog live if receiving appropriate therapy. These particular questions that center around prediction of risk are particularly difficult due to a wide degree of individual variation. And while we can't give precise estimates, we can try to give estimates that sufficiently allow owners and vets to make decisions and have realistic expectations. Finally, I will spend a minute talking about how to best engage owners, how to get them on board, and be a partner that understands the reasons for your recommendations and treatment decisions. I believe that effective client communication is an underappreciated part of mitral valve disease that can pay dividends in practice. The first thing I'd like to answer is, why does chronic congestive heart failure occur? There are two levels of knowledge I'd like to address. The first is something relatively simple that a pet owner can understand. The second is more nuanced and explains why and how the drugs we prescribe are of value, and how they primarily complement each other with little redundancy of function or effect. My usual explanation to owners goes something like this. Rusty has severe mitral valve disease, or DCM, and the leak in the heart valve, or weakened heart muscle, has decreased the heart's ability to pump the normal amount of blood out to the body. The kidneys are especially sensitive to lowered blood supply and try to correct this by increasing the amount of fluid in the body and by reducing the amount of urine they produce. The kidneys are stimulated to conserve both salt and water. The retention of salt helps increase the amount of water, as the two tend to move in and out of the kidney together. Unfortunately, the kidneys overdo this response, and they retain so much fluid that it begins to collect in spaces in the body where it should not. One of the places fluid likes to build up is in the tissues of the lungs, or in the chest or abdominal spaces. This abnormal collection of fluid is congestive heart failure. And in Rusty's case, the congestion in the lungs interferes with his ability to breathe. This is why you notice that he seemed to be having more effort and faster rate of breathing at home. This sort of explanation usually is sufficient to get most owners up to speed about what events transpired to cause their pet's signs. Now, you and I understand things more deeply, and it's good to review this as it explains the rationale behind the 4 cornerstone drugs used to treat congestive heart failure in the dog. If we consider a leaking mitral valve or poor myocardial contractility, it's obvious to see how these abnormalities reduce forward blood flow. And in the case of DCM, it's easy to see how drugs that improve contractility would be of direct benefit. In the case of mitral valve disease, it's the leak in the valve, not poor contractility, that is the centerpiece of disease. So what treatment targets exist with respect to the leak and poor forward flow? Let's consider the entirety of the mitral valve apparatus, including not only the valve leaflets, but also the valve annulus. That is, the ring of tissue that separates the left atrium and ventricle, and whose cross-section is the area that the leaflets must physically cover and seal during valve closure. Valve tissue has little ability to regrow or replace itself once injured. Thus, healthy leaflets are capable of covering a certain annular area and no more. Now, degenerative valve disease occurs, and the valve edges contract and form nodules. The chordae tendineae are disrupted, and the leaflet geometry in relation to the annulus changes, perhaps with part of the leaflet no longer supported and prolapsing backwards past the annulus and into the left atrium. Now take into account the fluid retention by the kidneys that is occurring downstream, and the fact that this extra blood volume has to be accommodated by the heart, and the fact that both the left atrium and left ventricle begin to dilate. As this happens, the annulus must also dilate. Its circumference and cross-sectional area increase similar to an expanding circle. Now we have the compounded problem of a degenerative valve that cannot seal even a normal-sized annulus, coupled with an ever-growing annulus because of fluid retention. These two factors lead to increasing amounts of mitral regurgitation, which leads to further reductions in output, heightened fluid retention, and even more annular dilation. You see the vicious cycle that is formed. We also know that annular dilation contributes to the development of secondary mitral regurgitation in dogs with DCM. How do we try and correct this? While it's not definitively proven, it's very reasonable to assume that increasing the ventricular contractility, even in the dog with mitral valve disease, makes the heart smaller in systole and will reduce the cross-sectional area of the mitral annulus and mitral regurgitation. It's my belief that this is one reason why drugs that increase contractility improve outcomes in dogs with mitral valve disease, despite the absence of a primary myocardial problem affecting contractility. Next, let's consider the kidneys' responses. You and I understand that the mechanism behind fluid and sodium retention is driven by neurohormonal systems, such as the renin-angiotensin-aldosterone system, as well as interrelated systems such as the sympathetic nervous system and vasopressin system, to name a few. Thus, we understand the rationale and value of disrupting these systems to relieve the avidity for fluid and salt retention within the kidney. We will talk in more detail about this in a few minutes. The aspect of treatment that is most intuitive to owners is relief of congestion by diuretic drugs. We simply are forcing the kidney to excrete fluid and salt despite its tendency to conserve. You and I recognize that many dogs on relatively high doses of furosemide continue to have congestion, and we can see where development of diuretic resistance or low diuretic responsiveness becomes a problem, particularly so for dogs on chronic therapy. We can also see where issues of owner compliance and ease of administration of medications, as well as dietary sodium intake, plays a role in whether or not a dog is successfully decongested. And so, it's very clear why it is that chronic therapy for heart failure uses the 4 drugs it does. Everyone here knows about these 4 drugs: furosemide, pimobendan, spironolactone, and ACE inhibitors, and it's hopefully clear to owners why and how each drug contributes to treatment of their dog. When we explain to owners in this fashion each of the 3 problems you identified, decreased forward flow, the kidney's response, and development of congestion, has 1 or 2 specifically assigned drugs to tackle each of the problems. I'm continually amazed at how little some owners know about the drugs they are giving to their dogs and why. A lack of understanding makes it difficult to ideally manage these patients, especially in circumstances where you might need to adjust, change, or modify their treatment. Here is how I describe each of the 4 drugs to the owner at time of prescription. Again, it positions each drug alongside one of the 3 problems we identified earlier in the discussion. Pimobendin is a drug that helps improve the strength of the heart muscle and, in the case of mitral valve disease, reduces the area that the valve needs to cover. Spironolactone and ACE inhibitor are used together to provide comprehensive blockade of hormone systems that cause the kidney to want to produce less urine and increase fluid congestion. And furosemide, a diuretic drug that promotes urine production to relieve or prevent fluid buildup or congestion. This 30-second explanation goes a long way towards getting dog owners the information they need to be effective partners in treating. It sounds ridiculously obvious and simple, but I also am amazed at how veterinary students, for instance, have trouble providing explanations such as this to owners. The students can talk about how pimobendin sensitizes the actin and myosin to calcium, how angiotensinogen is converted to angiotensin 1, and then ACE converts angiotensin 1 to angiotensin 2, and how this influences downstream aldosterone production and release, how furosemide works in the ascending loop of Henle. All important knowledge for a veterinarian, but a relatively useless explanation to the average owner. And so, both dog owner and veterinarian are now on board with an understanding of what it is the drugs are intended to do. Prescribing quadruple therapy is easy. What is more difficult is to make value judgments between each of the 4 drugs relative to each other. This might be of importance when considering external factors such as cost, ease of administration, and prioritizing one drug over another. What we are asking is, if the big 4 had to be reduced to the moderately sized 3, which drugs remain? Or the big 4 has to become the somewhat small 2, or even become the bare bones 1, which remain? This is a philosophical, scientific, and practical question for which you will get many answers depending on who you ask. I'll tell you my view with the honest admission that there are many reasonable ways to think about this. If relief of clinical signs of congestion, be it respiratory distress or discomfort or abdominal distension, what is not very controversial is the primacy of diuretics, typically furosemide. The dog's signs are a result of fluid in the pulmonary interstitium or alveolar spaces, and brute force removal of this fluid by diuresis is an obvious solution. Dogs don't come in with signs of high angiotensin II. They come in because the angiotensin II has contributed to fluid accumulation. Dogs with high angiotensin II but without congestion can be asymptomatic and appear perfectly happy, but dogs with congestion cannot. So it's to no one's surprise that if forced to do the bare bones 1 plan, it's diuretics. The next level is where it gets more tricky and complicated. Of the remaining 3, spironolactone, ACE inhibitor, and pimobendin, which is 2, which is number 3, which is number 4, and does it really matter? My definitive and unqualified answer is a firm and confidently stated, I don't know.
Here is one way to try and look at the problem. Each scale represents a clinical trial involving dogs with heart failure. On each end of the scale are the treatment groups that were compared against each other. Some studies are quite old. For example, the Cove and Bench studies are from the 1990s, while some are more recent, the most recent of which is the BEST trial, funded by this webinar sponsor and was reported in 2021. Let's look at each study and their results. Some of the very first clinical trials compared ACE inhibitors, such as enalapril or benazepril, on top of standard care, which at that time mostly involved furosemide and digoxin, against standard care without ACE inhibitors. Both trials demonstrated a favorable effect of adding ACE inhibitors. Both studies demonstrated better survival. One study was relatively short, ending after 28 days, and the other followed dogs for up to 34 months. Thus, ACE inhibition, in addition to furosemide, appeared better than furosemide alone. The next study is Bernay et al. 2010, which looked at the combination of spironolactone and ACE inhibitor versus ACE inhibitor alone, again against a background of diuretic treatment. In this study, the combination reduced risk of death, euthanasia, or worsening disease by 55% over a 1-year period. So, more complete neurohormonal RAS blockade was superior to just ACE inhibition alone, which was superior to no ACE inhibition. Let's move to the next study, performed in 2006 and another in 2008. These examined the combination of diuretics and pemobendin versus diuretics and ACE inhibitor. And in both studies, dogs receiving pemobendin fared better than dogs receiving ACE inhibitor. In the larger of the two studies, QUEST, the median time to death or treatment failure was 267 days in dogs receiving pemobendin and 140 days in dogs receiving ACE inhibitors. So again, ACE inhibitors are better than no ACE inhibitors. Spironolactone and ACE inhibitors is better than just ACE inhibitors, and pemobendin was better than just ACE inhibitors. The next study shown is VALVE from 2020, which looked at dogs receiving double therapy, that is pemobendin and furosemide, against triple therapy, that is pemobendin, ACE inhibitors, and furosemide, and found no difference in the time from first onset of heart failure and start of treatment to death, euthanasia, or treatment failure. The time in both groups was similar in around 200 days, and so the study was not able to determine if ACE inhibition and pemobendin was better than pemobendin alone. Finally, we come to the BEST study from 2021 that looked at triple therapy using a tablet that is comprised of both spironolactone and ACE inhibitor along with furosemide versus double therapy with ACE inhibitor and furosemide. And the combination of spironolactone and ACE inhibitor was superior. The combination, which represents more comprehensive RAS blockade, reduced risk of death, euthanasia, or treatment failure by approximately 25% over ACE inhibitor alone. Notably, this study did not involve use of pemobendin. So you see where this leaves us. Despite risk of being overly redundant, let's just quickly recap. ACE inhibition is better than no ACE inhibition. Spironolactone and ACE inhibition, whether given as separate tablets or a combined tablet, is better than just ACE inhibition alone. Pemobendin is better than ACE inhibition, and addition of ACE inhibition to pemobendin isn't necessarily better than pemobendin alone, which leaves us with an important, still unanswered question. What about comprehensive RAS blockade with both spironolactone and ACE inhibition versus pemobendin? This is a question that some of us might be worried about, but I'm here to reassure you that it doesn't matter if you continue to recommend quadruple therapy as is the current recommendation. Until someone proves otherwise, there are compelling reasons to believe that each of the three strategies we discussed, comprehensive neurohormonal blockade, reducing the mitral annulus area, and brute force diuresis, bring value to their treatment. In my opinion, it's extremely hard to argue that quadruple therapy is anything but the most appropriate therapy for dogs with congestive heart failure. In 2019, the American College of Veterinary Internal Medicine, Specialty of Cardiology, updated its guidelines for the treatment of mitral valve disease. This next slide summarizes the Class 1 recommendations, meaning that benefit far outweighs risk of adverse side effects, involving the use of quadruple therapy in dogs with congestive heart failure. Some commonly recommended doses are described. In thinking about this recommendation, for the reasons we just discussed, I would encourage you to think of this in the context of how these drugs are addressing the three primary problems causing chronic congestion. That is, neurohormonal blockade, hemodynamic support, and decongestion. In this way, what you are really doing is a three-pronged approach to heart failure, and you might consider this a form of triple rather than quadruple therapy, noting that your neurohormonal approach is not complete unless both ACE inhibitor and spironolactone are used. We just saw evidence for this in the previous slide. Once on this three-pronged therapy, you and owners will monitor for reoccurrence of signs of congestion, and when they occur, to gradually increase the dose of furosemide. It's typical to continue to incrementally increase the oral furosemide dose until you reach a total daily dose of approximately 8 milligrams per kilogram. For instance, a dog that is receiving 4 milligrams per kilogram PO twice a day. Standard therapy does well in alleviating congestion and maintaining high quality of life. But often noticed, particularly as disease worsens and doses of furosemide increase, that each incremental increase in furosemide is less effective at alleviating new congestion as compared to previous episodes. It almost seems as if diuretics are losing their potency or efficacy. It's not uncommon that when you ask owners of dogs that have had multiple bouts of heart failure and are on high doses of furosemide, if their dog is PUPD, they will tell you no. In many cases, they seem to believe that the amount of PUPD is far less than when they first started the drugs. This phenomenon of a lower diuretic responsive, or what some might call diuretic resistance, is a well-known phenomenon in human medicine. It is a result of a complex and often multifactorial set of circumstances that might involve the unpredictable oral bioavailability of furosemide, the fact that in severe disease with poor forward flow, delivery of the drug to the kidneys might be lowered. In addition, it is a well-established fact that the short duration of action and half-life of furosemide can lead to ups and downs in fluid homeostasis that promote resistance and further activate the RAS. For these and other reasons, furosemide is only one of several loop diuretics used in humans with chronic heart failure. We will discuss one of these additional drugs in more detail in the next few slides. The ACVIM consensus guidelines mention the loop diuretic torsemide, also called toracimide, as an alternative to furosemide. Torsemide, like furosemide, works in the ascending loop of Henle and blocks the same sodium and chloride transporter than furosemide does. However, there are some pharmacokinetic and dynamic differences that might be advantageous. These include more predictable and consistent oral bioavailability, a longer and more sustained period of diuresis related to the longer half-life and duration of effect. On a milligram versus milligram basis, torsemide is approximately 10 to 15 times more potent than furosemide. Hence, you will note the approximately 10-fold difference in the dose range of torsemide versus furosemide. One particular appealing aspect of torsemide is the potential for less resistance. This requires additional study in the dog. However, the general belief in human medicine is that this is indeed the case for torsemide and other non-furosemide loop diuretics, such as another diuretic called bumetanide. It is for these reasons that the consensus guidelines consider torsemide as a viable alternative in the treatment of chronic congestive heart failure. This, of course, makes one wonder whether or not the specific properties of torsemide or related drugs offer better long-term control of congestive heart failure. This question is relevant to human medical field, in which large studies of this very question are ongoing. In dogs with mitral valve disease, we have data from 2 studies showing that control of congestion is equally obtained when comparing the 2 diuretics. In a 2017 study, the primary study objective was to show that torsemide was no worse than furosemide at achieving successful treatment in the first 2 months. And another study in 2019 showed similar results over an approximately 3-month period. This indicates that you can treat heart failure with torsemide and not worry about treatment efficacy being substandard compared to furosemide. But the more interesting question is whether over the long term, dogs on torsemide fare better than dogs on furosemide. Both studies secondarily looked at this question and found similar results. Dogs receiving torsemide had longer time until death or worsening of heart failure. You can see that the relative reduction in risk is between 53 and 64% in the 2 studies. This does not mean that torsemide definitively is better than furosemide, but does help us plan and consider studies that will specifically look at this question. You will remember that torsemide is between 10 and 15 times more potent than furosemide, and as expected, there is a higher incidence of azotemia. In both studies, the very large majority of instances did not require lowering of doses or specific interventions. We know diuresis can cause prerenal azotemia or aggravate pre-existing primary renal disease, but for the most part, we are comfortable with mild elevations of creatinine and BUN as long as congestion is absent. Use of diuretics requires careful attention to hydration status and underlying disease. And one reassuring finding from both studies is that the incidence of severe adverse effects was relatively rare and no different between drugs. So let's add torsemide to our scheme as an option in place of furosemide. Next, let's circle back to this concept of anti-RAS therapy and the combination of ACE inhibitor and aldosterone. Why do we believe that neurohormonal therapy requires both of these drugs? The traditional view of RAS is a linear system in which angiotensinogen makes angiotensin 1, which makes angiotensin 2, which promotes aldosterone release from the adrenal cortex. Why is there benefit to providing 2 points of blockade, one at ACE and another one specific to aldosterone? The benefit has to do with a phenomenon known as aldosterone breakthrough. That is, the body finds ways to make aldosterone despite the upstream blockade of angiotensin 2 production. Aldosterone breakthrough, as described and defined in both dogs and humans, is a failure to suppress aldosterone despite upstream ACE inhibitor therapy. Aldosterone breakthrough occurs in approximately 30 to 40% of dogs with chronic heart failure. In this study from 2017, dogs with heart failure and receiving ACE inhibitor with aldosterone breakthrough are shown within the green circle. One difficulty surrounding aldosterone breakthrough is the ability to detect it in any individual dog. A single measurement of serum aldosterone is not a reliable indicator of chronic breakthrough, and other detection methods, such as urine aldosterone creatinine ratio, are not widely available. Thus, one cannot be certain if any given dog under your care has breakthrough, nor the extent if present. Given that as many as 4 out of every 10 dogs you treat likely have breakthrough, the recommendation for comprehensive RAS blockade with spironolactone in all dogs with heart failure is very reasonable. It is this concept of aldosterone breakthrough that gives plausible cause for why the combination of ACE inhibitor and spironolactone yields better results than ACE inhibitor alone. This was demonstrated in some of the results of trials we previously discussed, namely the 2010 study and the recent 2021 study. One difference between these two studies involves the specific formulation of the ACE inhibitor and spironolactone. In the 2021 BEST study, comprehensive RAS blockade was achieved using a single tablet containing both drugs. Let's look closer at this combination and the results of this study, which was funded by the sponsor of today's webinar. I was not an investigator in this study, but feel that the results drive home a couple of the points I've tried to make during this presentation. The study was a relatively large one, involving 414 dogs with mitral valve disease that experienced an episode of heart failure during the 10 days prior to enrollment. Dogs were randomized to receive furosemide and benazepril, or furosemide and a combined tablet containing a fixed dose of both benazepril and spironolactone. Each treatment was given daily for up to 360 days. The study endpoint was death or euthanasia due to cardiac causes or worsening of heart failure that required introduction of additional drugs or achieving a total daily dose of furosemide more than 8 milligrams per kilogram per day. The main study criterion was the percentage of dogs not experiencing or free of this endpoint at 360 days. The plot to the right shows the results. At day 360, 22% of the dogs in the spironolactone benazepril group remained alive or without treatment failure, as compared to 11% of dogs that were receiving benazepril only. Similar to the torsemide studies we discussed, this study also looked at the time from study entry to death or treatment failure as a secondary measure. This is a Kaplan-Meier curve that shows the survival functions of the two study groups. The y-axis can be looked at as the proportion of dogs still in the study at any given time, meaning the proportion of dogs that have not yet died or experienced treatment failure. At time 0, the day dogs entered the study, the proportion of dogs in the study is 1. Over time, as shown on the x-axis, dogs experience death or treatment failure, and the proportion of dogs remaining in the study falls. Over time, the population of dogs remaining in the study decreases, and one can see that the rate at which dogs in the spironolactone and ACE inhibitor group fall out of the study is lower than the ACE-only group. By drawing a horizontal line across the y-axis at the point when half the dogs have dropped out of the study, the median survival time of the groups can be compared. In this case, the median survival time in the combined spironolactone ACE inhibitor group was 105 days versus 69 days in the ACE-only group. And this difference was significant. Another way to describe the findings is that at any given time during the study, dogs receiving the combined pill had a 27% reduction in the risk of reaching the endpoint as compared to the ACE inhibitor only group. If you tabulate the reasons why dogs were removed from the study, you find that fewer dogs died from congestive heart failure related causes in the spironolactone ACE inhibitor group. Based on what we've discussed about the concept of comprehensive neurohormonal blockade and aldosterone breakthrough, I believe this makes sense. It's important to think about adverse effects and potential trade-offs when adding spironolactone, which is both a mild diuretic and aldosterone antagonist. We thought about a related situation in considering toracimide, a more potent diuretic that has a higher incidence of mild azotemia, but with potential survival benefit. This set of figures shows the incidence and risk of the combined drug relative to ACE inhibitor alone. On the left is the incidence of adverse effects such as vomiting, azotemia, diarrhea, urinary incontinence that was experienced by dogs in either group. In all instances, except for vomiting, the incidence of the specific side effect is similar between treatment groups. Dogs on the combined drug experienced a small but significantly higher incidence of vomiting. One particular point of interest is whether or not the added diuretic effect of spironolactone resulted in higher incidence of renal insufficiency. Numerically, slightly more dogs on the combined drug experienced renal insufficiency, but this difference is not significant. One might be tempted to explain this by the fact that while spironolactone is a diuretic, it's a very weak one, and its effect on hydration or renal function is probably small. Spironolactone's main value lies in its ability to specifically block aldosterone rather than produce large amounts of diuresis. Here on the lower left of the slide, with regards to the overall number and severity of adverse events, there was no difference between study groups. Thus, it appeared that the benefit of comprehensive RAS blockade can be done safely and without adverse effects. So to summarize, the part of heart failure that involves neurohormonal blockade. Hopefully I've conveyed my belief that it's the two drugs together that likely makes a difference. In fact, it's highly likely that any benefit of anti-RAS therapy is maximized by simultaneous administration of both ACE inhibitor and spironolactone. I would now like to discuss the final part of quadruple therapy, that is pimobendan. As you probably are aware, pimobendan improves myocardial contractility through calcium sensitization. What does that mean exactly? You recall that the myocyte and sarcomere has actin and myosin filaments that slide or ratchet past one another during contraction. The myosin head bends and pulls the actin one way, while the myosin arm moves the other way. For this to occur, calcium ions need to bind to troponin, which sits on the actin filament. In the absence of calcium, the actin and myosin do not interact and the muscle is relaxed or resting. What pimobendan does is to increase the affinity of troponin for calcium, so that a greater proportion of troponin molecules are triggered by calcium and the resultant contraction is stronger. As we mentioned, the benefit of increased contractility in cases of DCM is self-evident, but due to the interrelationship between heart size as it contracts and the mitral valve annulus, there is plausible reason why pimobendan has the benefit it does in dogs with mitral valve disease. So that's the reasoning in support of standard quadruple therapy for chronic heart failure. I hope this sheds light on the rationale behind the various recommendations and therapy guidelines. Next, I want to spend a few moments considering the situation where standard treatment is insufficient or not achievable. This might be due to the presence of severe disease, concurrent extracardiac disease, or difficulty administering medication on the part of the owner. Most often, the sign that standard therapy is not working is persistent or frequently reoccurring congestion, despite what you feel are adequate or recommended doses of the 4 drugs we discussed. There are many different reasons for this, and we could devote several hours to a discussion, but in general, I like to consider 3 possible categories. The first is insufficient dosing. That is, you fail to provide sufficiently high doses of furosemide or torsemide that might be needed, or that you fail to achieve these doses due to the fear of azotemia or renal insufficiency. Whenever possible, most cardiologists will attempt to increase existing loop diuretics to ranges such as shown here before moving to other strategies. And again, mild or even moderate azotemia without symptoms is not an automatic barrier to achieving these sorts of doses. The next category is a broad one and brings back the concept of diuretic responsiveness or resistance. As previously alluded to, diuretic resistance is incredibly complex and multifactorial, with many different pathophysiologic and pharmacologic entanglements. As a clinical entity, diuretic resistance or low responsiveness is defined as congestion despite furosemide at 8 milligrams per kilogram per day and appropriate anti-RAS therapy and pimobendan. It's easy to identify. It's the dog that always seems to have congestive heart failure and respiratory signs, despite lots of medication, and might be a frequent visitor to emergency room for acute respiratory signs. Causes of low diuretic responsiveness is a topic of great interest and study in both human and veterinary medicine. But when looking at a dog in your exam room, you will often be making some educated guesses about cause and subsequent treatment. This slide lists some common causes of resistance and specific related treatments. We previously mentioned that the oral bioavailability of furosemide is inconsistent and perhaps even more so in dogs with congestive heart failure. This might relate to concurrent GI disease, but could also be due to GI congestion in cases of right heart failure, changes in the microbiome, the catabolic state that many chronic heart failure patients display, or a host of other causes. Solutions might be to switch to oral torsemide for its more consistent oral bioavailability, or to see if owners are willing to learn how to administer sub-Q injections of furosemide at home. In my experience, this is a particularly effective strategy. In the presence of chronic loop diuretics in the ascending loop of Henle, the nephron's downstream segments attempt to increase water and salt retention, and distal convoluted tubule hypertrophy is an important mechanism. Another strategy might be to add diuretics that specifically target the distal convoluted tubule so that multiple areas of the nephron are prevented from retaining salt and water. Thiazide diuretics are often used. Remember that the dog's total sodium load is the difference between what is going in and what is going out. Diuretics concentrate on the egress portion, while dietary sodium makes up virtually all of the input into the system. Here, close attention to diet and oral sodium consumption can make a difference. Finally, underlying kidney disease might reduce the number of functional nephrons so that the total amount of natriuresis and diuresis is affected. We won't discuss this much in detail, but venous and arterial vasodilators are a way to reduce preload and afterload without having to change volume. So I want to provide a bit more detail about each of these treatments and how to achieve them in practice. In regards to replacing oral furosemide with oral torsemide, the conversion can be tricky. The exact ratio to perform this conversion can change based on disease severity, existing dose, concomitant medications, and the like. A general starting place would be to convert using a 1:12 ratio, 1 part torsemide for every 12 parts furosemide. Essentially, you take the daily existing dose of furosemide, divide by 12, and then administer this dose as torsemide either once daily or split into a BID dose. The conversion factor needed to control edema might be as low as 1 to 8 to 10, or as high as 1 to 15. We previously noted that the mitral valve disease guidelines include using torsemide in place of furosemide. And if one believes that torsemide is associated with lower resistance and better long-term outcome, starting torsemide from the beginning as the first choice diuretic might be a good choice. In instances where owners are willing to learn to administer sub-Q injections, you can replace one of the daily oral doses with a sub-Q injection. Because we are getting better overall bioavailability, you often can reduce the sub-Q dose to 50 to 75% of the oral dose. Next, some comments specific to hydrochlorothiazide, which is a diuretic with modest potency but works specifically in the distal convoluted tubule. Thus, it's well suited to be part of so-called sequential nephron segment blockade when added to existing loop diuretics. One thing to note is that when used in combination with furosemide, the dose of hydrochlorothiazide that I recommend is much lower than if it was used alone. Some formularies describe a hydrochlorothiazide dose between 1 to 4 milligrams per kilogram a day, which can cause severe dehydration or uremia if given in addition to pre-existing furosemide. The doses of hydrochlorothiazide needed for sequential nephron blockade are lower, around 0.25 to 0.5 milligrams per kilogram per day. Hydrochlorothiazide has a relatively long half-life, and starting once a day is often reasonable. Salt-restricted diets are another strategy, and finding ones that balance restriction while still retaining palatability might be a challenge. Diets in these ranges often represent a good compromise. Finally, with respect to additional vasodilators, ensuring comprehensive RAS blockade, perhaps increasing the ACE inhibitor dose to 0.5 milligrams per kilogram BID, or adding a third daily dose of pimabendin to take advantage of its vasodilatory as well as contractility properties could be considered. This brings us to a third cause of diuretic resistance, which is really a failure to administer diuretics rather than a pathophysiologic phenomenon, and that is poor owner compliance, be it due to misunderstanding, poor communication, or refusal of the dog to take medications. I suspect that this cause of resistance is underdetected by the vet and underreported by the owner. Many owners might be hesitant to discuss the fact that they missed doses, whether by accident or because of problems stemming from their dog. In one study, 3% of dog owners were bitten by their dogs when trying to administer cardiac medications. You might find ways to ask about success of administration in ways that are comfortable for the owners to discuss. I simply ask whether or not Rusty or whomever is good about taking pills and if any problems with the frequency or number of medications that were prescribed. In a recent study of owner compliance and opinions regarding treatment of dogs with chronic heart failure, 30% of owners said that the maximum number of medications they could consistently administer was 3 or less. So let's consider that for a moment. If true, 30% of your owners might not be able to administer quadruple therapy unless you can find ways to reduce the number of tablets. With regards to frequency, nearly half of all owners could not dose more than twice a day. This particular study was done at a tertiary referral hospital, where the clientele likely were highly motivated to provide care for their dog, and these percentages likely are even higher in frontline practice. You might directly ask an owner what the maximum number and frequency of potential medications are and try to tailor your therapy accordingly. Maybe this means using torsemide SID instead of furosemide BID. Maybe this means avoiding prescribing a TID oral furosemide dose, instead switching an existing PO dose to sub-Q. Maybe it means using a combined spironolactone ACE inhibitor tablet, which is given once a day to achieve your complete RAS blockade and reduce both the number of drugs and dosing frequency by 1. Is there any evidence that a lower dosing frequency improves compliance? In one of the aforementioned studies looking at once-a-day torsemide versus twice-a-day furosemide, dogs receiving torsemide had better owner compliance than those receiving twice-a-day furosemide. Being a clinical trial, the compliance numbers you see here are probably much higher than what really happens in practice. So while the compliance percentage seems very good in both groups, the other way to look at that is that despite being in a very intensive trial and receiving detailed instructions and guidance, in the case of twice-a-day furosemide, nearly 1 of every 10 doses were still missed. As you continue to manage cases of chronic heart failure, your cue to increase diuretics and intensify therapy primarily is clinical signs. If clinical signs are present, diuretic doses are escalated as needed, again being aware of renal function, but not necessarily stopping if mild azotemia occurs. One thing to note is that rechecking echocardiograms or chest films, the latter, particularly in absence of signs, is not necessarily helpful. There are, of course, instances when these tests are very helpful, but in the case of a small breed dog with a typical mitral murmur that has been on therapy and is doing well, performing echo after echo is not particularly helpful or needed. As we near the end of this presentation, a few comments about prognosis. There is no doubt that once disease has progressed to the point where congestion is evident, the prognosis is poor. Most dogs will experience death or euthanasia or become very difficult to stabilize and treat within the next year. Based on and extrapolated from various studies, one might expect that 50% of dogs on quadruple therapy will reach this endpoint within 9 to 12 months. This is a sobering statistic, but we continue to make advances in both the clinical phases and preclinical phases of disease. If there is one silver lining, it's that for whatever time the dogs have left, in the absence of frank congestion or severe adverse drug side effects, a dog's quality of life is usually very good. Dogs with chronic heart failure that are successfully managed, eat well, are appropriately active and interactive, and don't appear to be in pain or undue discomfort. When discussing prognosis with owners, I always follow up the 9 to 12 month statistic with this particular point. This is my final slide and includes a reminder of how the 3 main pathophysiologic events in heart failure are each addressed by standard quadruple therapy. I encourage you to use this as the basis for thinking about treatment and communicating the benefit of each arm of therapy to dog owners. The point is to engage the owner as much as possible in the disease and rationale for treatment in a manner appropriate to their understanding. Quadruple therapy is very effective at alleviating signs and helping maintain a high quality of life. Owners can be reassured that a good quality of life is well within reach. Once stabilized, owner-detected changes in their dog's respiratory rate and effort likely represents the most sensitive way to gauge efficacy of medications and need to escalate diuretics. Assessment of hydration status and renal function helps avoid adverse effects. Finally, I encourage you to engage in discussions about ease of medication administration. You want owners to feel comfortable in discussing challenges related to medication administration and to partner with you to try and reduce pills and frequency if needed. With that, I'd like to thank you for attending and to thank the sponsor SIVA for inviting me to speak.